Hello, I'm going to talk to you today about artificial intelligence in medicine, in particular, the need to translate from its basic science to providing clinical value. My name is Dr. William Hersh. I am professor and chair of the Department of Medical Informatics and Clinical Epidemiology in the School of Medicine at Oregon Health and Science University. I can be contacted by email. I have a website and I write a blog. I'm also active on social media, particularly Facebook and Twitter, and I have an ORC-ID for my scientific identification. I have been to your wonderful hospital many times, including one time when I visited with my daughter, who is seen in the picture here, and she now has graduated medical school and is in a residency in obstetrics and gynecology at Oregon Health and Science University. In my talk today, I will give some brief definitions of the terminology that I will be using. I will then be describing some of the results from AI and some of the challenges ahead. Most of you know the definitions of artificial intelligence and machine learning, but let me review them briefly so that we're all talking on the same page. Artificial intelligence, or AI, is the ability of computers to perform tasks that are normally associated with human intelligence. Modern AI has been greatly advanced by machine learning, or ML, which is the ability of computer programs to learn without being explicitly programmed. Machine learning itself has been advanced by new algorithms, enhanced computer processing abilities, and probably most important, the availability of large and diverse quantities of data. And a certain type of machine learning has also led to advances in capabilities, which is deep learning, and deep learning involves the use of multi-layered neural networks. However, we don't need to understand the math or the theory behind machine learning to understand its use or evaluation in clinical settings and whether it provides benefits or not to patients. Probably the most success of artificial intelligence and machine learning in recent years has come from image classification. Some of the early studies showing its benefit were done in areas such as diabetic retinopathy. You see the picture of the retina in the upper left, histology of cancer and metastases seen in the lower left, diagnosis of diseases from chest x-rays such as tuberculosis and pneumonia, and images of the skin and being able to diagnose things like skin cancer. A state-of-the-art of machine learning for image classification was published by Estiva in 2021. These successes do go beyond images. For example, there have been a number of successes in clinical prediction using AI. So, for example, studies looking at processing medical records to be able to predict in hospitals length of stay, mortality, readmission, and diagnosis. The ability to determine age and sex from things like retinal images and electrocardiograms. The ability to provide early risk of chronic kidney disease in patients who have diabetes, or to predict dementia from data in the electronic health record for up to 2 years before a clinical diagnosis of dementia is made. And then finally, in the COVID-19 pandemic, prediction models for the need for mechanical ventilation, renal replacement therapy, and readmission to the hospital. As with everything we do or advocate to do in medicine, there must be evidence for benefit. So what is the evidence for the clinical benefit of AI? As with any kind of intervention, whether we're talking about treatment or prevention, the best evidence comes from randomized controlled trials, ideally trials that are well designed, whose results can be generalized, and whose results are reported well so we can understand what was done and how we can make use of those methods. There are other clinical questions we can ask besides whether an intervention works, and some of these can be answered by AI. For example, can AI improve our ability to diagnose disease? Can we identify harms that occur either in the environment or for medical care? And also, what might be the prognosis of health and disease? Ultimately, however, if we advocate AI for interventions to use in healthcare, we must demonstrate experimentally that there is benefit to patients, to clinicians, and populations. There are some instances where randomized controlled trials are not feasible, so sometimes we can apply other methods such as observational studies. Often, when there have been enough studies performed, researchers can do a systematic review where all of the studies are brought together and reviewed in a systematic manner. Such a systematic review was recently published in the journal MPJ Digital Medicine by Zhao and colleagues, and they looked at the clinical impact and the quality of randomized controlled trials involving interventions using AI and predictive tools. They reviewed all randomized controlled trials using different methods for AI, and they grouped them into three categories: so-called traditional statistical methods, mostly regression; conventional machine learning methods, basically all machine learning but deep learning; and then deep learning methods, mainly making use of neural networks. Overall, the studies were found to have AI used for assistive treatment decisions, assistive diagnosis, and risk stratification. This table from the paper summarized a number of the characteristics of the 65 randomized controlled trials that were identified. About 61% or 3/5 of the trials had positive results, meaning that there was a shown benefit for the AI intervention. The studies looked at a variety of different disease categories, including cancer, other chronic disease, acute disease, and primary care conditions. All different types of algorithms were used, with the traditional statistical models being studied most frequently, followed by machine learning, followed by deep learning. And all predictive tool functions were used, most commonly assistive treatment decisions, followed by assistive diagnosis, followed by risk stratification. There was some concern of bias in a number of the studies. For example, 1/3 of the studies had no sample size estimation, meaning that they did not choose a sample size that would likely result in a statistically significant difference if there was one. 3/4 of the study used no masking of the AI system, meaning it was a so-called open label study where the users of the AI system knew they were using that AI system, which can potentially lead to bias. The majority of studies did not reference the consort statement, which is a checklist of what should be included in a randomized controlled trial. The majority of the studies did not use intent to treat analysis, nor did they provide access to their detailed study protocols. One caveat about looking at studies from the standpoint of whether they're positive or negative is that the number of positive studies or the number of negative studies does not necessarily indicate a general superiority or inferiority of methods. You can't simply count the number of positive studies. But of course, it is good to know how many studies are positive versus negative to see if AI can make a difference in these different areas. The analysis also looked at the characteristics of the clinical trials by tool type, looking at things such as the input to the models that were developed, the disease categories that they were used for, the function of the tools, and the results. The inputs to the model varied by tool type, with traditional statistical and machine learning models tending to use clinical quantitative data, such as structured data from the electronic health record, and images for deep learning tools. And all in all, there was very little use of natural language that is in medical records. For the disease categories, it was found to be variable for traditional statistical tools. the machine learning tools tended to focus on chronic disease and the deep learning tools tended to focus on cancer. In terms of the function of the tools, there was a focus on risk stratification and treatment for the traditional statistical tools, a focus on treatment for the machine learning tools, and on diagnosis for the deep learning tools. And then in terms of the results, they were mixed for the traditional statistical tools, some positive, some negative, and tended to be more positive for the machine learning and the deep learning tools, though those were used in a more focused way. The paper also includes some figures that look at trends over time and also compare the different types of prediction tools used. Note that there is an error in the legend of subfigure C because it should read type of prediction tools as is seen in subfigure D. But in any case, we see that there is an increasing number of studies per year over time. We also see that there is more recent use of deep learning as that technology became more widely available and used. There doesn't appear to be much difference in the proportion of positive versus negative studies over the years, as shown in subfigure B. We do see that as proportions that there are more positive studies as a proportion for deep learning than machine learning than traditional statistical methods, although we must remember the caveat from the earlier slide that the number of positive studies doesn't in and of itself mean much. I mentioned earlier about the concern of risk of bias in many of the clinical trials of these methods. In fact, only 17 of the 65 trials were rated to have a low risk of bias. The types of things contributing to high risk of bias are listed in the upper figure, and the lower figure shows the risk of bias based on the type of AI model, with the risk of bias being highest in the traditional statistical model studies, then the machine learning studies, and lowest in the deep learning studies, but still with a fairly high risk of bias in many studies. The particular problems were things like the suboptimal use of the consort statement that describes the elements that should be reported on in a randomized controlled trial, the lack of sample size pre-estimation to come up with a number of patients needed to demonstrate a clinically significant benefit, unclear use or reporting of randomization, and putting patients or not putting patients into an intent to treat analysis for the AI tool. This table from the paper looked at the characteristics of the 11 clinical trials that used deep learning tools. Of these 11 trials, 9 of them evaluated assisting endoscopic procedures, most commonly for colorectal cancer, and they all had positive results. There were 2 other trials that had negative results. What do we conclude from this systematic review? Well, we know that AI predictive tools show great promise in improving clinical decisions that are made for diagnosis, treatment, and risk stratification, but at this point, comprehensive evidence for their value is lacking. The number of clinical trials that assess clinical benefit is still small. The majority of these trials have concerns about methodology and are rated to have indeterminate or high risk of bias. And most of the trials of deep learning are focused on one type of procedure, namely endoscopic procedures. There's also some concerns about this review. There are a number of typos in the paper, including a missing column in Table 2 of the deep learning interventions that I was only able to get by contacting the author. There's also a more recent positive study by Yao et al. That's not included. That was probably published after the review had been done. It's difficult to use the data in a supplementary table of machine learning interventions because it's in a PDF file and not easy to browse through. It also includes a reference that is in the paper by Winberg et al., but is not in the table, making one wonder that perhaps this is a traditional statistical method and not a machine learning method, but that's not made explicit. And then there's no data or table at all for traditional statistical interventions. There are other aspects of AI that have raised concerns, a number of which relate to the finding of the systematic review that the methodology of these studies is not always as good as it could be. One concern is replication of studies. Oftentimes a study will get done in a particular area and it will never be replicated with different patients at a different institution in a different country and so forth. Koyera recently noted that almost no clinical decision support studies in the informatics literature have been replicated. Another concern about these studies is that the machine learning algorithms may be learning on non-signal features, in other words, idiosyncrasies or other aspects of images or other idiosyncrasies of data sets, and not on the actual clinical signal. That, of course, could be problematic when a tool is moved to a new setting where the images or the data don't have those idiosyncrasies. There continue to be concern about the poor quality of studies. One paper looked at the use of AI on screening mammography data sets. It noted that the quality of most of the studies was poor, that all of these studies were retrospective, in other words, based on a data set that had already been collected and not prospective, and generally the results were inferior to radiologists. There have also been concerns about the myriad of studies that have looked at prediction models for COVID-19 prognosis. The studies in general have been found to be poorly reported and show potential high risk of bias. Another COVID-19 study looking at chest X-ray for diagnosis of COVID-19 found that many of the studies had inadequate reporting of their methodology. Another concern is that machine learning for health in general compared poorly to other areas of machine learning regarding metrics around reproducibility, such as making data sets available, making code available, and so forth. And then finally, of 130 medical AI devices that have been approved by the U.S. Food and Drug Administration, only 4 of them were evaluated using prospective methods, and oftentimes the number of evaluation sites and samples were not reported. What can we conclude about the use of AI in medicine? Clearly, there is much promise. The results from different data sets in different areas of medicine show that these models can learn and potentially be deployed to benefit patient care. But for the most part, clinically proven benefit for these methods, especially deployed in the real world, is mostly lacking. So we need translation. We need to translate from that basic science success to demonstrating clinical value. How do we do this? Well, we need to have clinically driven applications of AI and then clinical trials to evaluate those applications, ideally replicated in different institutions, with different patients, with different imaging equipment, or however we collect the data. There must be attention to patient safety and patient benefit, in that we don't want the AI to harm patients, and there must also be attention to the clinician, in particular to make sure that the AI does not disrupt the workflow of the clinician. In general, we need robust AI and randomized controlled trial methods that are replicable and generalizable. And of course, we must conduct the implementation of AI and the trials that study it from a health equity standpoint to make sure that all people benefit. Gracias for listening to my talk, and I will be happy to answer any questions that arise. Thank you.
Okay, thank you very much, Bill, for the presentation. There's a question from Paula. Paula, should I read it out loud or would you like to say it? Okay, I'll read it.
Just let me, yes, because I wrote it, but it's easy if I say it. So first I will say it in Spanish and then I will say it in English. Con todo el tema de COVID se desarrollaron muchos algoritmos y todo el mundo quería hacerse famoso por tener el algoritmo para diagnosticar COVID o eventualmente qué neumonía podía llegar a complicarse. Y eso de alguna manera en la charla de Bill lo que uno puede ver no ha demostrado ser de todo efectivo. Entonces esto no puede transformarse en una barrera para lo que es la implementación y el crecimiento que está teniendo la inteligencia artificial. So, Bill, by now you should know Spanish, so I don't need to translate this question to you, but I'm going to just do it for you. No, the thing is, during the COVID pandemic, a lot of AI algorithms were developed so as to diagnose pneumonia by COVID and to predict complications. And many of them did not came to light showing, like you said, clinical benefits. So do you think that might become like a barrier or a hurdle for AI to continue growing?
Well, yeah, I mean, I think
You're
it's probably.
muted, Bill, eh?
Oh, sorry. I'm
I
I'm
can
not.
hear you.
No, sorry. I was muted.
Can you hear me now?
Yeah, definitely.
Okay, great. Yeah, well, I mean, I think this is true of COVID in general, that everything has been rushed, whether it's studies of treatments done too fast and so forth. I think we need to be careful. I still think we need to take the time to evaluate things. And also once we do evaluate things, if they don't show benefit, then we need to move on to something else. So, certainly there's urgency with COVID, but we have to be careful not to go too fast, really in all aspects of COVID, not just AI.
Good.
Thank you very much.
Another question that I was yesterday we had a talk by Peter Enby and also by John Halanka about how to evaluate these algorithms and not them to be black boxes. So we would like to know if there's somehow like the new thing about algorithms is that they need to be transparent, evaluated, and ensure the equity for all the population.
Yeah, that's a great point. It's interesting. As you may know, we had Eric Topol as a speaker at the AMIA conference this year. And he's a very thoughtful person about AI. And actually because there is this issue that, especially like deep learning algorithms, they just don't explain what they do. They just give you an answer. He argued that it's more important for them to be transparent and trustable. How were they developed? Were they tested in objective ways so the process was transparent? For example, there was a big issue with some of the algorithms that Epic uses in their electronic health record. They're proprietary algorithms. No one knows how they've been developed, and they actually have very mixed performance. They work well at some places than others. They need to be as open as possible. Some would argue that all of their details, all of their source code, we may never get to that point, but certainly algorithms have to be trustworthy, and their evaluation has to be as open as possible if we want to advocate clinicians to use them, and if we advocate for patients to want them to be used in their care. So it's very critical, and Peter Enby is a very eloquent spokesman about that, and agree with his approach.
Candelaria, I will mute myself.
Thank you very much. Thank you very much for the questions and for your time. Um, I I have another question from the chat. Daniela Herrera asks, AA is a promising tool to optimize the healthcare delivery. How can we accomplish sustainable and affordable systems for low-income countries?
Great. Well, it's thank you. Good to see Daniel, who's in Chile and is a student in my 10 by 10 course. That's a good question. You know, how do we roll it out, you know, to the world? You know, I think the good news is that these days, most modern computing and internet technology is relatively affordable. So, you know, again, I think it goes back to the, you know, transparency and trustworthiness. We need to have these, you know, algorithms in the same way be tested and evaluated in a open manner in these sorts of areas in lower middle income settings where it may be more difficult, but hopefully the same principles really apply, whether we're evaluating it, you know, in the United States or Argentina or Chile.
Right, very interesting. I have another question of my own. How do you see the adoption of these kind of systems by the clinicians? Is there a different attitude to the adoption in different departments? Maybe like some departments within the institution are more prompt to embrace it and to make a part of it, and others are a little more reluctant.
Yeah. I mean, it's hard to know for sure. You know, it's hard to generalize about departments, but you know, we've certainly learned a lot from our last decade of electronic health records. You know, in the United States, at your institution, and we know that when we don't meet the needs of clinicians, when we make their workflow more difficult, when we make them enter data, when we give them answers they really don't want and so forth, that they don't like using our tools. You know, even though at least in the case of electronic health records, we're not gonna go back to paper. I don't think anyone's really advocating that, even those who don't like their electronic health records. But we need to make the systems useful to clinicians so they can take care of patients. Their workflow doesn't get bogged down. And I think the same thing will occur with AI. Are the tools giving them useful answers? I mean, that you know, we're kind of in a second generation of AI at this point in time. You know, the first generation from, say, like the 1980s, and the systems back then were really not that useful. I think probably the systems these days will be more useful. You know, especially if we can demonstrate it in these clinical trials and so forth, and that will hopefully lead to their uptake.
Great, thank you very much. One last question by Fernando Binder. Many AA initiatives seem to be driven by private stakeholders, such as AA startups. As someone who works in an epidemiology department, to what extent do you believe AA can address public health priorities?
Sure. I think those are really two different questions, and I know we're a little short of time, so I will try to quickly answer both. You know, it's clear that there's a lot of startup companies, and actually not only startups, but also the big tech companies, and you know, they have a lot to offer. Although, you know, certainly in the United States, and I think probably elsewhere, they've not really displaced the traditional Epics and the Cerners and so forth. Whether it's the big tech companies or the startup companies, they need to be cognizant of the needs of healthcare. I think that sometimes you know, companies they're maybe not willing to work with how healthcare works. They're not really, they're focused on the gee whiz kind of part of technology and not providing care for patients. So to the extent that they do that, I think that there should be a good role for them. And then the question about addressing public health priorities, absolutely. Certainly in the United States, I think in a lot of other countries, you know, where our information systems were not as well prepared for the COVID-19 pandemic as they could have been. And so hopefully we'll learn from this and pay more attention to public health. So in the future, when there's pandemics, when they affect different age groups, they affect different geographic regions, there's new rollout of vaccinations and things like that, that we can hopefully be able to track that data better so that we know what the what's happening with the pandemic and how new treatments and vaccinations are working and so forth.
Great. Amazing. Well, thank you very much, Dr. Hersh. We are very happy that you could make it to be live. It's a pleasure for us to have you here in our event. So thank you very much. Any other questions that the audience would like to make to Dr. Hersh, you can leave them in the chat, and we will answer them through that through the chat as well. And well, I will switch to Spanish back again.
Mm-hmm.